Okay, folks, I am going to do your third of 4 modules for this part of the concept, managing care. So when we look at this module, we see the module assimilates the concept of managing care, focuses on prioritization with individual care and groups of patients and clients. Now, Ms. McHargue, how in the world do I learn to prioritize? Well, over time, it takes time is the best way to say it. And this semester, we're going to work on prioritization. When you get into capstone, prioritization is a huge part of capstone and a big part of capstone journals. So, and it'll make sense, I promise. But if you need help, again, like I've always said, get to one of us and we'll help you the best we can. We want to get you through this, get you to boards, be able to pass boards, and get you out there practicing. Learning objectives for this is, once you're finished with managing care, is to outline strategies to prioritize client care. We're going to go over those in the PowerPoint, and then utilize Maslow's hierarchy of prioritization for individualized care. Now, we did Maslow's way back then in Nursing 111, so bring it back out. I do have a slide in the presentation about Maslow's hierarchy, which will help. And then also with this one, there are 2 articles, but like I said, the complex world of RN's implications of a healthy work environment and enhancing critical thinking in clinical practice are the 2. Not optional reading, folks, they're required. So let's go straight to this and get into the presentation. So when we look at concept of managing care, there's lots of things that we need to talk about. Although this is probably the shortest PowerPoint presentation, but there are some interactions between. And again, like I said earlier in the previous 2, I'm going to post a forum so I can hear what you got to say. No responses, just forum discussion. Responses are optional. And you can, just so that I can hear what you have to say. Prioritizing client care. So what is critical thinking? That's part of the forum that we're going to put up. What do you think critical thinking is? How do you put it together? How do you make it make sense? Critical thinking involves the interpretation, according to nursing education, and analysis of a problem or problems. Putting reasoning into it to find a solution, applying the reasoning, and finally utilizing evaluation of the outcomes. And that was a study published in 2010, although that seems to be 11 years old now. That article is a very good article, Nursing Education. It is careful, deliberate, focused, based on scientific method and nursing process. Y'all know what nursing process is, and a high level of knowledge. You will gain that knowledge in years of experience. Just in clinical alone, remember back where you were in the first day of clinical to now, where you are now, and by the end of this semester, you'll think, wow. And an experience over time, including professional standards. Critical thinking also involves constantly asking questions. If you think it and you're not sure about it, then you need to ask. Never be afraid to ask questions. Examining information and evidence to come up with a solution and figuring out conclusions. That's why in the very first module, I set out to get you on the Joint Commission website so that you could find resources, and there's help as well. So in critical thinking, if you can't figure it out, get help. Get help from your charge nurse, get help from your nurse manager, the nursing supervisor, and a colleague or a mentor. We'll talk about mentors in the next part. In clinical nursing, when you're in practice, it is the ability of nursing to see patients' needs uniquely and respond appropriately beyond or in spite of orders. Now, let me explain that one just a little bit. When I'm taking care of a client in critical care, clients complaining of chest pain. And in the process of complaining of chest pain, I have to assess that client. I have to assess the pain. What's the level, 0 to 10? What's the intensity? Where's it at? Does it radiate? And also, because it's a critical care patient and they're complaining of chest pain, I am going to do a 12 lead EKG, because when I call the provider, he or she are going to say, did you do A, B, C, D, E before you called me? Got a set of vital signs, most recent. So those things you're going to put in process so you can uniquely respond appropriately. And you're going to have standing orders in critical care once they're initiated that you can carry out will also help. It's basically making a decision. We're taught as we are raised by our parents or whomever raises us to make a decision between right and wrong. If we know what we need to do, we need to do it. So critical thinking skills are used to help nursing learn and to prioritize. Now, part of those definitions were pulled from articles, and some of them were put together and pulled from your textbook, and they're on page 8 in your med-surg book. So when we look at prioritization is the organization of activities according to the order in which they should be done. So when we talk about that in a little, let's think about BLS. What comes first? Airway, breathing, circulation, or circulation, breathing, airway? We have to put them in order to carry out what is appropriate and safe for the client. Prioritization is one of the most difficult skills for new nurses to learn. And I would say that prioritization is not always new nurses. It can be experienced or seasoned nurses can become disorganized and trouble with prioritizing. But again, in capstone, this will help greatly. And remember that saying that I said early, knowing normal helps you recognize what's not normal. Right care to the right patient at the right time for the right reason. So how do we prioritize? Is it an emergency? Number one, is it something I need to stop what I'm doing and take care of right now? Patient codes? Yes, absolutely. You got to stop what you're doing for other patients, and you got to take care of the situation right here, right now. Trends versus isolation. Got a patient on the monitor, although we're looking at the patient first. Do I notice a trend of the heart rate going up and the blood pressure going down? Do I have a GI bleed patient that's bleeding and the heart rate's going up, and I'm losing my blood pressure because the patient's becoming hypovolemic? An actual before a potential. Do I have an actual problem of hypotension, or is the patient who come to me post-operatively, could they have a potential for hypotension? Many reasons that they could. Anesthesia, number one. Number two, fluid volume loss. So things to think about. Systemic before local. Back in 211 when we talked about immunity, if it's an anaphylactic reaction, it seems to be more of a systemic, the whole body, or is it just a local reaction that we're having? Think about your client in critical care that could have a local reaction with angioedema to ACE inhibitors. So something to think about. acute before chronic. If the problem is acute right here, right now, just started happening, then we have to think about that before it's someone with chronic problems, somebody that's COPD, somebody, and you'll learn all these complex disease processes this semester with chronic diseases of dilated cardiomyopathies, or somebody that's been burned and they have chronic problems post being burned, PTSD, chronic. So we're looking at all those things. When we look at them, we need to take into consideration Maslow's hierarchy of needs. Time management. Can I do this by myself, or do I need some help? Infection control. Think of the things that we talked about in safety. I can't jump from one room to the other, go suction one patient that's got MRSA growing in the lungs, and take care of my post-op surgical patient that needs pain medicine. I have to stop somewhere in between for infection control. Compare any of this to what's normal. Can I detect normal and abnormal? And the client demographics. So let's talk about an emergent situation. So you have a patient in critical care in the emergency room or wherever you may be, dialysis, cardiac cath lab, will be some other areas that you go. When we speak of airway, we have to assess the airway. Is the patient breathing? Are they having trouble breathing? Is their breathing, already jumped to B, is their airway established? Is their airway open? And this can be up to a 5-minute window or less that we need to take care of this airway. I would say less than 5 minutes. But breathing, if the airway is open, are they breathing? Are they tachypnic? Are they ready, not breathing very well? Do we need to assist their breathing? Do we need to bag them? Do we need to intubate them? Is what we are doing effective? How do you know that the airway and breathing is effective? If you're giving them 100% oxygen, then we should know their oxygen levels should start coming up, or then we're in trouble, more trouble than we thought. American Heart Association and BLS kind of gives us a guideline about an emergency situation. So when we discuss airway issues, vented patient that extubates themselves, can we watch them? What if they start having stridor? We'll need to re-intubate them or continually watch them, check their pulse ox, check their breathing, listen to them. Can they talk to you in full sentences, or are their words broken and can you just visually see that they're short of breath? Asthma exacerbations with low SATs. What are you going to do for this asthma patient? Can you give them a breathing treatment first? How fast are they breathing? How tight are they when you listen to their lungs? I'm getting excited because I'm talking fast. Calcium channel blockers and angioedema and ACE inhibitors, hypotensive meds. If you've never seen a client with angioedema, go back to 117 and look at those pictures that I showed you way back when. We're talking full facial swelling, and sometimes these folks end up with trachs. Post-op patient on nasal cannula getting too much pain medicine. So say, for instance, you have a back surgery patient that's been laying prone for hours on end while they're in surgery, and they come to you post-operatively in the critical care, and you hook them up to the monitor, and you notice that the respirations are only 8, and they want pain medicine. Well, you can't be you are the deciding factor of whether they get pain medicine or not. But what do you have to take into consideration before they get pain medicine? They're only breathing 8 times a minute. Is it really safe to give them something for pain? Rapid responses to the floor with the patient SATs in the 70s. You got to think about what you can walk into upstairs when you're in critical care and you are the rapid response leader when you walk upstairs or answer a rapid response. And in the process, if you have somebody with SATs in the 70s, you need to go back to the previous screen, and we need to think about acute and chronic problems. Where are their lungs? Where have they been? So you need the nurse who has been taking care of them during this whole time. So in breathing, back up one more, we got to look at assessing the breathing, watching them breathe, establishing an airway. Is the patient apneic? What is their respiratory rate? What is their pulse ox? And how are we going to fix this problem? All these things tie into prioritization and critical thinking. You've already done some critical thinking as you've gone along. So circulation and D, A, B, C, D. So let's talk about circulation. When you talk about circulation, we're talking about the heart. So are they being perfused? We've talked about perfusion. And if their heart's beating, can you feel their pulses distally? Are they perfusing to those distal pulses, or have they already shunted down and all their blood's moved to their core? Do you have a pulse? You see this monitor, nice, pretty, and all. Miss Coffey's going to teach you about rhythms. So you see a nice, pretty rhythm marching across the screen, and your patient's laying there kind of sleepy looking, and they're not really responding to you. And then you decide that they're not responding at all, and you make sure that they're breathing or they're not, and they don't have a pulse. Well, that's a pulseless electrical activity, patient's unresponsive. So you have to start CPR. Lots of things to think about. Disability. If I don't act quickly and if I don't take care of the problem and I can't decide what I need, can I holler for help? Absolutely. If we don't take care of the problem, then the patient or the client's going to end up with some kind of disability. The biggest one that I can think of that comes off the top of my head is a hypoxic patient and brain anoxia. The outcome of that is not good. So if we slow them down too much, then we end up leaving them more disabled. So let's skip to a scenario. You're caring for a client that's just been extubated. That means the endotracheal tube has been taken out of their throat and off the ventilator. They're complaining of pain, 6/10, in their lower left extremity. What's going on? What are you thinking? So I don't really know a whole lot more other than I came in to help Susie get this patient situated because she's in another room taking care of another patient. They just extubated. The patient wants to know, can I have some pain medicine? Raspily saying, pain assessed 6/10. What's the priority in the situation? What's first? Are we talking airway we got to watch? Or are we going to treat them for pain right away? So we stick around for a little bit because I'm not crazy busy. Been doing charge all day. And we assess their airway and we listen to their lungs and we hear wheezing and we hear stridor. You ever heard stridor? It's a high-pitched wheeze or a high-pitched sound in the upper airway. And so you're listening to that, but what does that mean? What does that tell me? Is my patient moving air throughout their lungs if they have stridor? What nursing actions am I going to do? Am I going to sit them up, check their pulse ox, take their vital signs, count their respiratory rate? I'm going to go find Susie, who's been taking care of this patient all day. I'm going to ask, hey, has your patient been having stridor? Have they been having wheezing? How's the breathing been? So we establish that the airway on the monitor, their respiratory rate's up to 24, and we're monitoring, it's about 92, 91%. And we decide that having them on a little bit of nasal cannula oxygen will help. So the nasal cannula oxygen brings their stats up to 94, 95%. The intensivist pulmonologist says keep stats greater than 92%, but they're still really wheezy. Who can I pull in my boat to help me? I'm thinking respiratory therapist. I hope you are. So we give the patient their breathing treatment. We give them a little bit extra oxygen. And what are we going to do? We're going to have to watch them and see how things are going to go and treat them accordingly. And some people who've been extubated, that end up with stridor, have to be re-intubated and put back on the ventilator. All right, moving on to the next scenario. This is an actual scenario that happened to me in practice. So I was taking care of an elderly lady. She was diagnosed, came in with GI bleed, bright red melena, and her hemoglobin on admission was 7.5. What's normal? See if you can remember. Currently receiving a liquid prep, go lightly, which should be named go heavily, for scheduled colonoscopy tomorrow. So the client's monitor had been normal all day, stable, no tachycardia, no hypotension, we were good. And the client becomes restless. And I asked her, I said, what's wrong? And the client says, I got to go to the bathroom. She's taking a prep. So I need to decide, because the bathroom is way back behind the bed, or a bedside potty chair. I think a bedside potty chair is probably safer at the bedside, because I don't know what's going to happen to her, right? So she is really, really restless, and she's asking, I got to get up, I got to go to the bathroom. I said, well, we'll compromise, and is the bedside potty chair okay? And she says, well, I reckon. So, should I get her up while we're not? Think about those things. She said, I've got to go use, and she says, I cannot use a bedpan. So we're not going to the bathroom, I said. We'll just use the bedside potty chair. So my nursing judgment says, okay, we can get her up, bedside potty chair, get it beside the bed. You're alone with this client in the room by themselves. Because they have been stable all morning, I feel like I'm okay to be with her by myself. But then you decide, should I have really gotten her out of bed? Why or why not? And as I'm standing there, I hear this monitor, ding, ding, ding. It's a red alarm. So I look up at the heart rate, and it's 170. And I'm thinking, uh-oh, we got to get back to bed right now. And her heart rate had not been over 80 all day. Within seconds, she slumps over, her forehead hits my shoulder, and she is out cold. And now I'm thinking, what am I going to do? So, of course, I know who I'm working with. So I holler for one of my coworkers, and he comes in there with me, and we pick her up and we put her back in the bed. And she, I guess from the jolt of throwing her back in the bed, I shouldn't say throwing her back in the bed, but pretty much her heart rate had calmed down. But because she was hypovolemic from bleeding, that caused her heart rate to climb quickly. That orthostatic hypotension, when we stood her up, dropped her vital signs. I'm glad I didn't leave her by herself. And I didn't get her back to bed by myself because I thought, got to be safe. I don't want her falling. And luckily, we got her back to bed and she was okay. And we continued the prep, and no more potty chair, no absolute to the bathroom. And I just completely explained to her, look, you already passed out once, ain't happening again. Why was her heart rate high? So we talked about that, because her hypovolemia and then the orthostatic drop of her blood pressure. Scary situation. So when we talk about trend versus an isolated event, is it a gradual or repeated change in a one-time event? A trend usually signifies something deeper or more serious. Should I assess and reassess? Absolutely. Do you need to investigate further? Absolutely. Does the healthcare provider need to know? Well, you need to assess first, take some vital signs, and figure out a game plan, and then call the healthcare provider within a very quick amount of time. Don't delay. And how do we need to see why the trend is happening? So with this lady prior, I knew her vital signs had been good. Heart rate had been in the 80s. Blood pressure had been in the 110 range. And I decided to get her up to the bedside potty chair. And let me tell you something, I will never forget that whole scenario. And I just tell people, sorry, if I have a sneaky suspicion that their heart rate's going to change or their blood pressure is going to change, bedpan it is, or we'll put diapers underneath you and just go from there. So trend in isolation is a trend signifies something more serious. Is the trend showing you heart rate is gradually climbing up, or is it an isolated event or having arrhythmia on the monitor that goes away and never comes back or happens once or twice more? So let's talk about a scenario trend versus an isolated trend. So we need to know some vital signs, right? So we need to know a pain scale, a level of consciousness, neuro assessment, Glasgow Coma scale, part of the neuro assessment, and a urine output. I'm going to gather some good information. So we have a change in some vital signs that we note in the trend. And you are documenting vital signs every 30 minutes on this client as you're titrating drips. And you note that the blood pressure is gradually getting lower. Why? Is it because I'm titrating down on my drip that's altering their blood pressure? Or am I sitting still from titrating and the blood pressure is slowly creeping down, trending down? It's a post-op patient, been to the OR, just arrived to you from surgery. The report was that vital signs have been stable the last hour while they've been in PACU, but this patient had to have some neosynephrine during the case. What's neosynephrine and why would I use neosynephrine? Well, that's to help my blood pressure stay up, right? Is it going to change my heart rate? That's why anesthesia likes it. So is this an isolated event or a trend? So you're documenting some more. You note 2 more episodes of the heart rate below 50 on a patient with a diagnosis, your other patient, with a new onset of syncope. And questionable rule out some dysrhythmias. Well, we're bringing them to ICU, hooking them up, got them on the monitor. No other episodes noted in the last 24 hours. Cardiology comes through, they look at the monitor, they see that there's not been. Is this a trend or an isolated event? Hopefully you said isolated event. Later in the day, you note that on your cardiac patient, your monitor's been showing some PVCs, premature ventricular contractions. Ms. Kofke's going to teach you all about rhythms. So should we watch those PVCs? Should we note how often they're having them? Absolutely. So we talk about a patient, another patient, they're having some pain. And this patient's in 501. You just received a report from the night shift RN. And as you are doing your morning assessment, you ask the client about their pain. The client states, oh, I am hurting so bad. This is about an 8/10, and I can't really stand up much longer. It's been that way all night long, but the nurse only gave me pain medicine once, and the patient is 2 days post-op knee surgery. And she just gave me something by mouth. It's not really helping any at all. So the client's been working with PT twice a day for 3 shifts. And you go back to look at the MAR and discover the client has been getting the same pain medicine since surgery, and it hasn't been effective. Later, it's discovered the nurse that you received a report from was taking the pain medicine due to her back pain and giving the client her personal Tylenol. It's happened. I know it sounds crazy, but it's happened. So we have another client with a level of consciousness change. You're working in the critical care, you're caring for this client, just intubated on the ventilator. Now the pulmonologist initiates the standing orders for ventilated patients. You'll learn about that in the Mitchell Community College ICU. On the order set is for propofol. What's propofol? Do you know what propofol is and why it's used? With an order to titrate for a RASS scale of -2. Well, what's a RASS scale, Miss McHargue? It's the scale you determine how deeply sedated that your client is. And a -2 is what the standing orders say. So that's where you need to be. So you initiate the drip and the patient slowly becomes sedate to a -2. Why are they becoming so sedate, so sleepy? I can't get them awake. What's going on? I need to figure that one out. So these are some things that take you through the thought processing of critical thinking and determining what is a priority, who is a priority, and which action I need to do that becomes priorities. So is it an actual or a potential, now versus maybe? Is it a systemic versus localized, a whole versus a part? Is it an acute versus chronic, a new versus old? And infection control, we have to think about our immunocompromised versus our infectious patients. And generally, we treat the actual problem first before the potential, because we know that potentials can happen, but I have to be ready to treat them. So then the problem with that is already should be taken care of before the problem, the potentials, the actual should be taken care of before the potentials happen. So with our two clients to rule out a GI bleed, one with a low hemoglobin and the other one with not, I need to be taking care of the low hemoglobin first before my other client becomes a potential problem. So falls seem to be, we talked about in patient, national patient safety goals about falls. So we need to be monitoring our patients with falls, and we use the fall scores. We need to fix the systemic issue over the localized. In an emergency situation where the client has a broken arm and is not breathing, we have to fix the breathing first. And there's no need, if we don't, then there's no need to fix the broken arm, right? The shock over a laceration, we have to fix the shock before we can fix the laceration. What if it's a deep laceration, and are they going to become hypovolemic? Your A-line, arterial line patients that you're monitoring on the monitor, you want those alarms on so you know when that A-line, arterial line reaches a pressure of 0 or low before it gets to 0, so that you can treat it right now instead of waiting. What about our patients with blood sugars out of control that's never had the issue with blood sugars before? We need to figure out why. In the meantime, we have to treat the blood sugars. So you have to think about these 4 things, and these are going to help you prioritize and figure out what you need to do first. So let's go to Maslow's hierarchy. So on the bottom where it says physiological needs, physiological is food, sleep, oxygen, sex, and excretion. So I need air, I need water, I need food. We need shelter to stay warm, especially this time during the year. And I would also say that we need cool in the summertime. We need sleep. If we don't get enough sleep, we get sick. We need clothing because we don't need to be walking around naked or anything like that. We'll just leave reproduction off for now. If I'm taking in food and water, I should have the ability to excrete both of those. Then we talk about safety. We talked about the National Patient Safety Goals. Shelter, remove you from danger. Want to think about your personal security. So scene safety, you paramedics, is a big one. Social, some call the socialization, love and belonging. Self-esteem, having my own options of choosing the care that I need. respect for others, recognition and strength and freedom, self-actualization, desire to become the most that I can be. And that is the top of Maslow's hierarchy of needs. So when we talk about these, we have to make sure that our clients, patients, are getting these needs met. Now let's talk about levels of priority. First level is threats to the immediate survival or safety. Demand immediate nursing interventions, ABC. Am I breathing? My airway patent? Do I have circulation? So on and so forth. Then second level is acute pain, acute urinary changes. My urinary output has dropped off. What's normal urinary output per hour? Abnormal lab results. I need to make sure that I can keep up with all of those. Risk for infection. Am I immunocompromised? Safety, security, medical problems needing attention. Third level of priority or prioritization is does not fit into all categories. Monitoring of these medication side effects, patient knowledge of why they're taking what they're taking, long-term problems with living activities. These are things that we can fix or get help for over time, not necessarily have to be the first level, but we need to consider, is it something we need to fix now? Or do we need to fix it? Do we have time to fix it later? Additional principles for prioritization. Know the needs and priorities for each patient that you have, and you will establish those as you take care of people and more people over time. And Capstone is going to help you with that. Consider all the factors that are involved. Back to that one slide in the verses. Is it an actual or is it potential? Is it an isolated versus lost my train of thought. Isolated trend versus a trend multiples, a systemic versus localized. So that slide, know those four reasonings. So just remember in prioritization, one of the key things is always remain flexible. Things are going to change, people are going to change, events are going to change, vital signs are going to change. Be creative. Figure out what works for you. Stereotyping, no need, because we know that not all septic patients, you're going to learn this, are all the same. There's different kinds of sepsis. Things happen. But not everybody's going to be the same and have the same responses. All right, expected abnormals. If you have a client that's come to the hospital that you're taking care of, they're in critical care, expect some abnormals. If we had a pneumonia patient, would we expect their white blood cell count to be high? We had a GI bleed patient, will we expect their hemoglobin to maybe be a little low or lower, or their red blood cell to be low? If I had a patient with pneumonia, they were having trouble breathing, I check their oxygen sats and I see a 90, 91. Is that an expected abnormal? So we have a pancreatitis patient. What labs would we look at? Is the amylase and lipase levels, are they normal? Is that expected? And we have an MI, a cardiac patient, a heart attack patient. Elevated troponins, what's normal? Those are the things that you're going to commit to memory that you've been working on those last 2 years. They're going to help you make these decisions. Priority setting traps. Well, what does that mean, Ms. McHargue? So let's think about the things that we need to do first. Whatever hits first, ABC, path of least resistance. In the trap of this, the individual makes the assumption that it is easier to do a task by himself or herself and fails to delegate appropriately. Well, guess what else you're going to get to do when you do Capstone? You're going to learn to delegate. You have a CNA. You have a good CNA, your day's going to be great. If you're not good to your CNA, then your day's not going to be good. You need the extra help. You need the extra people. Squeaky wheel in this way of a trap. The individual falls prey to those who are most vocal about their request. I need pain medicine. I need it right now. It cannot wait. I can't take this anymore. So then we get the squeaky wheel. In this trap, the individual, that's what I just said, falls prey to those who are most vocal, and they don't regard those who are quiet and don't say a whole lot. Default, the individual feels obligated to take on tasks that no one else has come forward to do. When you're assigned a group of patients, you better stick and make sure that you are taking care of your clients. If you have extra time, then reach out to others. So an inspiration in the trap, this way of being trapped, is individuals wait until they become inspired to accomplish a task. What kind of person can you think about is lazy and they're delegating to everybody else to do their work? Some tasks will never be inspiring, and the wise time manager recognizes that the only thing that will complete these tasks is hard work and appropriate attention to what's going on right now. Time management takes time. There are days up until the last couple of years that if I was working in critical care and I would first go in on Saturday morning and I'd work Sunday, my time management may be a little better because I knew my patients a little better. And then sometimes on Saturday, my time management was crazy. So immediate is what needs to be done right now. Time frame, antibiotics, you have a window of time to give those. Which one do I need to give first? End of shift, things that can wait. You can do them during your shift and they're not prioritizing them to have to be done right here, right now. Which one's going to take me the least amount of time to complete? Is it something I can go do, get pain medicine, and give it to them in a 10-minute window and then go back and reassess my other patient that I just gave pain medicine to 30, 45 minutes ago? Do I have a pre-treatment, a pre-med that I need to give to a client before they go to surgery? So be proactive versus reactive. Proactive gets you in the mind frame of understanding and realizing that if you go ahead and take care of it, then you're not going to be reacting when it happens, and it possibly could be, you could get in trouble because something could happen to your patient or your client. They're depending on you to take care of them. I hope this has helped with time management, prioritization with your clients. Remember the 2 articles that go along with this lecture. So print those off and read them. They're not an optional read, they're a required read. And unfortunately, all this information is not in your book. So make sure you read your articles because you'll see them on your tickets and you'll see them in lecture and so on and so forth. So end of number 3. One more.